everybody. My name is Paul Green, and I'm a member of the Public Education Committee for ADAA, the Anxiety and Depression Association of America. Welcome to our webinar, Understanding and Managing Chronic Pain and Its Relationship with Mental Health, with presenter Dr. Risa Weisberg. These webinars are presented by ADAA, the leading nonprofit organization in the field of anxiety and depression. ADAA's mission is to improve diagnosis and promote the prevention, treatment, and cure of anxiety, depression, and stress-related disorders through education, like this webinar, practice, and research. We encourage you to take advantage of the many helpful resources on our website, adaa.org. I'm delighted to introduce our presenter, Dr. Risa Weisberg. Dr. Weisberg has devoted her career to developing and scientifically testing scalable interventions for common behavioral health problems. Her mission is to expand the reach of high-quality, science-based behavioral health treatment. She has over 2 decades of research, clinical, and leadership experience, which she now brings to lead the clinical direction and research strategy of behavior. Risa has a doctoral degree in clinical psychology from the University at Albany. She completed a doctoral internship and postdoctoral fellowship at Brown University. She is a professor of psychiatry at the Boston University School of Medicine and an adjunct professor of family medicine at the Alpert Medical School of Brown University. She is an expert in cognitive behavioral therapy and acceptance and commitment therapies. As a primary care psychologist, Risa has broad experience in treatment development and implementation for common behavioral health problems, including anxiety, depression, chronic pain, substance use, and adaptation to living with other chronic medical difficulties. Her research has been funded by the National Institutes of Health, the Patient-Centered Outcomes Research Institute, the Veterans Administration, and numerous foundations. Risa is a member of the Scientific Council of the Anxiety and Depression Association of America and a fellow and former board member of the Association for Behavioral and Cognitive Therapies.
Thank you so much for the introduction, Paul. I'm delighted to be here today to talk to you about understanding and managing chronic pain and about its relationship with mental health. Before we get started, I just want to give some disclosure information. As Dr. Green mentioned, I am currently the Chief Clinical Officer of Behavior Inc., and we are a for-profit company that develops CBT and ACT treatments in virtual reality. And we do have some chronic pain interventions in the market and are developing some others. So that is a disclosure that you should be aware of. So I'll get started with a definition of pain and chronic pain. So pain itself is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage. There's a lot to unpack there, which is why I'm starting with a definition. So by definition, pain's unpleasant. And by definition, it's not just something that you feel in your body, but it's also an emotional experience. And it can be associated with actual damage, but sometimes it's really associated with potential damage. And that leads right directly into the definition of chronic pain, which is that you have that pain and it lasts at least 3 months. Some people define it as 6 months, but that the source or the cause of the pain is often ill-defined. So sometimes with chronic pain, it's not directly associated with actual tissue damage occurring. And very importantly, that in chronic pain, the pain no longer serves an important warning function. And we'll get back to that and talk more about the warning function and alarm function of pain in just a bit. Chronic pain is extremely prevalent. We know that 1 in 5 Americans will experience chronic pain at some point in their life. And if you're a veteran, the chances are much higher. About 50% of veterans who receive their care at the VA experience chronic pain. So this is a highly prevalent problem. It's also very closely associated with other types of mental health problems, including depression and anxiety. So this is a very large national epidemiological study, and they found that individuals who had chronic pain, 17.5% of them also had a mood disorder, and over a quarter of them also had an anxiety disorder. So these things often travel together. Chronic pain also, not surprisingly, probably to many of you, also often comes with insomnia. And people who have chronic pain are 18 times more likely than the general population to have insomnia. I think for a lot of us, the thought is that the pain is what keeps you awake at night, and that is certainly true for a lot of people. But interestingly, research has found that there's really a bidirectional relationship between chronic pain and sleep difficulty, and that poor sleep may actually, in some cases, precede pain, or when you have chronic pain, lead to the worsening of pain. And so those things really feed back into each other in a bit of a vicious cycle. The other problem that, not surprisingly, probably most of you can often travel along with chronic pain is addiction to prescription opioids. So we know that back in the earlier part of this century, many providers were prescribing opioids specifically for their chronic pain patients. And when you think back to that prevalence slide, that it's about 1 in 5 people who have chronic pain, there's a lot of opioid prescriptions going out there. Numbers started to come down a little bit as we learned more about the negative consequences of prescription opioids, but still maintained pretty high. And so in 2017, this is our latest data, 17.5% of the US population received a prescription for an opioid. And we also know that in 2020, over 16,000 Americans died from an overdose that involved prescription opioids. So lots of opioids being received and really negative consequences for folks. These rates are much higher, 5 times higher in 2020 than they were back in 1999. And many of these individuals who died from prescription opioid overdose were first exposed to their opioid for treatment of their chronic pain. So there's a lot of things that are all pretty negative feelings and consequences that travel along with chronic pain. People with chronic pain are more likely to experience anxiety and depression, sleep problems, and opioid use problems. And unfortunately, people who have anxiety or depression are significantly more likely to develop problematic use of their opioids when they're prescribed those opioids for chronic pain. So this can often really lead to a bundling of lots of difficulties in living all at once for people with chronic pain. Not surprisingly then, your folks with chronic pain have lots of interactions with the medical system, and unfortunately, they're not always pleasant. Hopefully this data looks better now. I couldn't find anything more recent. And I'm hoping with more and more education about the suffering that individuals with chronic pain are going through, these numbers look better. But this was a large survey of primary care providers back in 2011 in terms of their attitudes and feelings in treating chronic pain. And unfortunately, they were predominantly negative. At that point, only 15% of family physicians agreed with the statement, "I enjoy working with patients who have chronic pain." And a lot of the words that they used to describe their experience working with these patients or what patients with chronic pain felt like to them were time-consuming, demanding, non-adherent, drug-seeking, and even impossible to please. Not surprisingly, chronic pain patients are then routinely dissatisfied with the treatment that they receive in primary care. This is a contentious relationship in a lot of ways for a lot of people. You're suffering, you're experiencing a lot of difficulty. Sometimes you're experiencing additional difficulty because your provider prescribed you an opioid medication to treat that pain and now is maybe telling you that you need to come off it. And that feels confusing because you feel like it's the one thing that's helping you. Or perhaps you feel you need to come off it and you know that you're now suffering from further opioid addiction and there's anger and frustration because it was your doctor who was trying to help you who got you started in the first place. Some of primary care providers' difficulty relating to treating chronic pain patients comes from the fact that doctors go into doctoring because they want to help patients. And it's frustrating to have patients for whom they feel like they can't really help. So this often comes from a very good place. It's coming from this feeling of they want to be able to make a difference in their patients' lives. They want to make an impact. They want to end your suffering. And unfortunately, chronic pain is hard to treat. And sometimes people just don't get better. And that they've gotten themselves involved, unfortunately, in many cases, in the sort of vicious cycle related to opioid use in that they know that they maybe were prescribing this to patients and now really feel a very strong ethical responsibility to get their patients off of opioids, and yet it's difficult for patients to come off. So from their perspective too, it doesn't necessarily come from a place of not wanting to help. It comes from a place of really, really wanting to help, but this being a difficult thing to treat and a difficult relationship. So what are the treatment options for individuals with chronic pain? Well, we already talked about why opioids are not really a great solution. Surgery sometimes then is thought of as a good backup solution. Unfortunately, it's not a cure-all for everyone. Only about 60% of individuals with chronic low back pain experience even minimally clinically significant decreases in pain after they have spinal surgery. And there's actually been some other data from large systematic reviews where there's a number of studies where they'll actually compare sham surgery. So that's actually where a patient believes that they're going in to have a surgical procedure done, a specific surgical procedure. They're put under anesthesia, an incision is made, but the surgery does not take place. This is obviously all with consent and people know they're part of the study. And comparing that to having actual surgery done, orthopedic surgery done. And a number of systematic reviews have shown that for a number of different kinds of surgeries, not only spinal surgeries, but from some knee surgeries, other joint surgeries, there is often no difference between sham surgery and actual surgery in terms of the effects on pain afterwards. So surgery does work for a number of people, but it's important to have a full conversation with your providers before taking this on. In part because of the difficulties related to opioid use and also to some of this data about surgery and how invasive it is, the most recommended treatment guidelines for frontline treatments for chronic pain are psychotherapy, which is predominantly cognitive behavioral therapy, including other branches of cognitive behavioral therapy like acceptance and commitment therapy, or what's often called ACT, and mindfulness treatments, and NSAIDs, things like ibuprofen. Second line are then antidepressant medications, which can often have a strong anti-pain response, and also acetaminophen. Fortunately, there's also a lot of other non-pharmacological, non-invasive treatments that do work for individuals with chronic pain. So this was a large systematic review of clinical trials for non-pharmacological, non-invasive, non-surgical treatments, and looked at both sort of short-term effects and longer-term effects on both pain and functioning. And you'll see that a number of interventions, that some of which are widely available, massage, yoga, just getting regular exercise, acupuncture treatments, spinal manipulation, and multidisciplinary rehabilitation, which is typically done at a pain center where you're getting physical therapy in combination often with some other types of treatment, whether that's acupuncture or massage or some components of psychotherapy. That these treatments all really had some effect on both pain and functioning, and many of them both in the short term and the long term. But if you look at that top line, the effects for cognitive behavioral therapy, mindfulness treatments were really the strongest and the most sustained at both short term and long term.
So related to that, Dr. Weisberg, I wonder if I could jump in with a couple questions that I think some of our viewers might have. Well, first of all, about CBT, I wonder if you can explain to people a little bit more about what that is and how it's understood to help with chronic pain.
Absolutely. Actually, I have a few more slides going through some of that. So that was a great question. So one of the key components of CBT is providing education about pain itself. And this actually pain neuroscience education has also been tested really just as a standalone treatment too, or tested in combination with physical therapy and with getting some exercise. It's a really essential part of cognitive behavioral therapy for chronic pain. It's one of like the cognitive pieces of cognitive behavioral therapy is better understanding what pain is and isn't. And there's evidence that this pain neuroscience education can be effective on its own, even without full cognitive behavioral therapy. So a lot of that involves learning the difference between acute pain and chronic pain. And so when you're getting cognitive behavioral therapy for pain, there'll be a lot of time spent on this kind of psychoeducation, explaining better, learning better what chronic pain is. And a lot of this will define pain in this manner. So in both acute pain and chronic pain, your pain is real. I tell all of my pain patients, don't listen to anyone who says pain's in your head unless they're treating you for headache. Any other pain is in the part of your body where you're feeling that pain, and it's also in your brain and in your nervous system. But if you're feeling pain in your knee, that pain's in your knee. If you're feeling pain in your back, that pain's in your back. Your pain is real. The differences are that with acute pain, the pain lasts for a relatively short period of time and tends to reduce over time in kind of a gradual and systematic way for the most part. And the pain is there as a really normal response to some type of injury or maybe some underlying medical condition, a fever or something like that that you might have at the time. And it's there because it's serving an alarm function. It's there as a signal of tissue damage or that there's some type of underlying medical condition, and it's there to protect you, right? So, it's that example of putting your hand on a hot stove. You immediately pull your hand away before you even have time to think, oh, wow, my hand hurts, right? Because if you left your hand there any longer, then you would really do more damage. So it's trying to tell you really, really quickly, do something to stop this pain. Pull out of the situation you're in because you're gonna hurt your body. And so it's completely normal because it's part of why pain is there, that when you feel pain, you wanna stop doing things that bring it on. That's what pain is designed to do. Unfortunately, with chronic pain, the pain lasts longer than that alarm system is useful. And so it'll last at least 3 months, maybe even longer. It's not reducing over time. And the cause of the pain is sometimes at this point now unknown or unrelated to other medical findings. And really, your providers may not understand exactly why you're still feeling pain, why your pain didn't go away after your body healed. And so at that point, it's really more of a false alarm than it is an active alarm for you. The other difference is really in response to treatment, right? So when you have acute pain, it gets better typically with some short-term medication, but that may not really be the case with chronic pain. And it starts in chronic pain to really affect the quality of your life in other ways that we already talked about, and your mood and your experiences. And so a lot of CBT will focus on helping people understand these differences so that they have a better sense of what pain means and doesn't mean. Cognitive behavioral therapy really is about cognitions, or what you think, behaviors, what you do or don't do, and sensations, physical sensations in your body, what you feel. And so with pain, it's really about this link between the physical sensations you feel of pain, how you respond to them behaviorally, what you do or don't do in response to them, and the thoughts you have about that pain. And CBT will focus really on trying to change mostly your thoughts about the pain and what you do and don't do in response to the pain, in hopes of then breaking that feedback loop to change what you feel in your body. So more of the focus is on what you think and do in response to the pain. One of the big pieces of this has to do with the idea of pain catastrophizing or fear of pain. And so again, pain is there to make you afraid, right? It's there to say, stop doing what you're doing something harmful. So there's nothing about you that's abnormal or having some other kind of issue if you're afraid of pain. First of all, pain's aversive. That's the very definition of it. No one wants to feel pain. And so we all want to avoid things that feel aversive. And it's there to scare you, to make you stop doing what you're doing. So it's completely normal that a lot of people who have pain develop a fear of that pain. But that fear of pain can really lead to this vicious cycle where you're then avoiding things that might bring on any pain, which then can cause really like muscle disuse or depression because you're avoiding a lot of things in your life, which can make the experience of pain worse and kind of have this feedback. Fear of pain is very strongly related to this concept called fear catastrophizing. And this is actually over on the right side of the screen is a scale measuring the pain catastrophizing. And so just thinking about some of these items here for yourself, how much when you have your pain, do you feel like it's really something you can't suffer through anymore and that it's just overwhelmingly awful? And how fearful are you that it's never going to go away? Because unfortunately, those types of thoughts can really contribute to this vicious cycle. And cognitive behavioral therapy, the cognitive piece of it, will help you break down some of those thoughts and really examine the evidence for them and how well do you know that you really can't cope with this and how much are you able to cope and change some of your thinking about the pain. behaviorally, it'll try and get you moving again, so that you're a little bit less fearful of movement, and movement that might bring on the pain.
So let me ask a follow-up question, if that's all
Sure.
right. I'm sure some people suffering from pain who might be watching, are wondering how it is that their thoughts might be relevant to the pain when the pain is real.
Absolutely. So though the pain is happening in your body and the pain is real, your thinking can influence physical sensations in your body for sure. And one of those ways is through attention. And so we know that when people are experiencing a lot of pain, it's really hard to focus on anything else. And especially if you're fearful of that pain. One of the things that happens when we're afraid of something is that our attention gets really focused on the thing that's dangerous and that we're afraid of, right? And again, that's adaptive. That's supposed to be the case. If you're in danger, you don't want to be thinking about what you're having for dinner, right? You want to be thinking about how do I get out of this dangerous situation? And so our bodies do this really good job and our minds do this really good job of focusing on the threat. But if that threat is pain, then you're focusing on the pain a lot. And we know, unfortunately, that the more you focus on a physical sensation, the more you feel it. There's this idea called symptom amplification that really comes from focusing on the symptom. I'll sometimes have patients just kind of close their eyes for a minute and think about whether or not they feel anything itchy and try and find an itch in their body anywhere. And then once they can find that itch, to really focus in on it and try to think about nothing else but that itch. And typically most people after a while will start to scratch. And you didn't necessarily think you were itchy before we started that. And I think it's a good way to kind of see that like your thoughts about like, oh, am I itchy? Where am I itchy? And your attention on that can really change the physical sensations that you feel in your body. And the same is very much true for pain.
That makes a lot of sense. Thank you.
Thank you. So I want to talk a little bit about an intervention that together with some of my colleagues, both at Brown and at Boston University, Dr. Lisa Ubelacker and Dr. Mike Stein, that we developed for treating chronic pain, really to talk about this more in a way of whether I think some key take-home messages that you might be able to try to employ in your own life based on this, this intervention. And we've thankful for the National Institutes of Health who have funded a number of trials on this intervention. So the idea here, the main ideas of this treatment is that we know pain's aversive and that it's something we all want to avoid. And that unfortunately though, in an attempt to avoid or prevent having more pain, and also to avoid having that accompanying sadness or anxiety that goes with pain, we can end up giving up a lot of what we value in life and what makes our life worth living. Our lives can get really small when our day-to-day experience is about how do I feel less pain? How do I suffer less? And unfortunately, when we give up what we value in life, we just feel more depressed and more anxious. And we can then also feel potentially more pain. And we also conceptualize opioid use, if that's something that you're also troubled by, as this really normal attempt to cope with your pain or avoid your pain, or potentially also to avoid anxiety and sadness. And so this is our very simplified model of that relationship between pain, anxiety, and attempts to prevent feeling worse, and that those things can really link back into each other. And so we help people to try to understand some of that in their own lives and what that pattern might look like. And so I think we'll talk more about how you might be able to do that for yourself. But one of the important pieces is that this intervention is based on acceptance and commitment therapy, which is a very well-established treatment for chronic pain as well. And in that, the focus is really on increasing your functioning. And so the idea is you've probably gone through a lot of treatment already, attempting to take away all your pain, and you're still feeling it. And that's super frustrating and super hard. So we don't even try in this treatment to say we're going to take away your pain. Sometimes it happens for people that once you increase functioning, the pain goes away too, because that's kind of the model. But our focus isn't directly on that. Our focus is on helping you to live the life you want as comfortably as possible. And so sometimes that means doing things even though they hurt. And it really includes taking your focus a little bit away from what do I want to avoid or prevent, and towards what do I want to be, what do I want to do, what do I want my life to be about, even if my life is about that with the pain on board. So the core messages we hope we can teach patients are, again, I think I've probably said this a number of times here, but I think it's super important. Everyone experiences pain, sadness, and anxiety. They're there because they're adaptive, they're warning signs in your body. And it's natural to want to avoid them. There's nothing wrong with you for that. Everyone wants to avoid emotional and physical pain. But in learning that difference between acute and chronic pain, it's really important to understand that just because something hurts, it doesn't mean it's dangerous. And it doesn't mean that it's actually causing more harm or more damage to your body. And that because of that, sometimes it's worth working towards something that's really important to you in your life, even if it might temporarily bring on more discomfort or more pain. And those are really the core things that we want people thinking about and trying to kind of change their perspective a little bit in relation to. We typically start with having you really focus on your story. And so whether you do this by journaling or by speaking it out loud, recording it, doing a blog, thinking it alone in your room for some time, we really encourage you to sit and think a little bit about your history with depression, anxiety, opioid use, pain. How did this all start for you? What was your path? And to take some time to really acknowledge your suffering. There's often a very devalidating experience of having chronic pain. People in your lives, your medical providers, don't always necessarily understand what you're going through. You're suffering a lot, and to take some time to really, really validate that for yourself, and then be honest with yourself about what it's taken away from you. What have you had to give up? Where would you be right now if it wasn't for the pain? What would your life be like? What would you be doing? And then to give yourself actually some permission to grieve that. It's a loss. There's a loss of things that you've probably gone through, whether that is you can't do the same job that you used to do before you had an injury, or it's changed the nature of relationships that you've had. Like giving yourself some permission to grieve for those losses. And in that grief, to be looking for signals about what you really value and what your long-term goals might be. So to talk more about that, values are really what you care most about in your world and how you want to be in the world. And they can really guide you towards what you want. They are directional. They're not sort of something you check off and say like, oh, I did this and I accomplished it. They're things you want to do long-term. Getting in touch with your values is often about thinking, gosh, the thing I'm grieving for the most right now is the loss of this job I had. I had to go on disability. I couldn't do this work anymore. And so what is it about that that's making you feel so sad? Was it the opportunity to wake up every day and feel like you had a purpose in your day? Was it the income that you brought in and what that afforded you? Was it the relationships you had at work? Was it feeling like you were making a difference? Tapping into the pieces, the values that you lost in that and grieving that job that were most important to you will give you a signal towards what you really value, and then how you can live your life more in service of those, even if you can't ever go back to that exact same job. This is a really handy tool. It's called the Chronic Pain Values Inventory, and you can find this online. That helps you kind of align with figuring out what it is that you most value and where you're doing in terms of living your life in accordance to those. So you can kind of see where those gaps are for yourself. And then we ask patients to, once you kind of figure out what those things are, values, start to set some long-term goals. What do I want to do that kind of check off my list that might get me to those long-term values, or might get me in service of those values. So for example, if your value is that you really want to be a kind and loving parent, and you feel like that's been really difficult with your pain, you're feeling you're more snippy to your family because you're in pain, or you're spending less time with them, maybe a long-term goal might be that you want to be there to support your child to do well in school. That's something that you can't do today though, right? You can make a step towards that today, but you can't check that off your list today. Today, I'm done helping my child do well in school. It's a long-term goal. I'll take several steps. So that's about setting short-term goals that might get you along that way. And those are things that tell you what you could do today to start living your life a little differently. So, for this example, it might be that you're going to set some time aside this week to help your child with their homework, and you're going to keep that appointment with your child, even if you don't feel well. Or you're going to take your medication as prescribed, so you can better be there for your family. We find that setting short-term goals works best when you use kind of a SMART system, and we'll teach you those as well. And so be thinking about this as you're setting your short-term goals for yourself. We try to set goals that are specific, so it tells you exactly what you want to do. So it's not just like, oh, I'm going to help my kid this week, right? It's like, I'm going to sit down on Monday and Wednesday nights for 20 minutes and help John with his math problems. They're measurable. You have a clear idea of knowing that you met your goal. If I sat there for 20 minutes, I met my goal. I don't get to say I didn't meet my goal if like John wasn't happy to have my help. That's not what the goal was. The goal was just to sit down and help him for 20 minutes. If I did that, I met my goal. They're achievable, right? So you can achieve that even if your son's like, Mom, I don't want your help. If you just tried for those 20 minutes, you achieved your goal. Relevant in that they get you sort of along that path to your long-term goal. And time bound, right? It's a very clear deadline. I'm going to do that this Monday, and clear timeline for getting done. Those are really the keys to success, to short-term goals for anything, whether it's related to living your life and your values for pain or getting other things done. Along the way, for really almost all treatments of cognitive behavioral treatments, acceptance-based treatments of chronic pain, you'll learn something called time-based pacing. I think this is an important concept for you to be thinking about. It's a really common experience for people in pain and chronic pain to find, there's days where you really feel like, even though there's this misconception of chronic pain that's since it's always there, it's gonna always feel the same. That's just not the case, right? So you're gonna have good days and bad days. And it's very common for people on their bad days to really be inactive and feel like they need a lot of rest and not get a lot done. And then to kind of feel depressed or guilty about the fact that they haven't done much. And so then they'll have this like huge spike of activity. I haven't cleaned my apartment in 2 weeks. And then all of a sudden I'm going to clean the entire thing from the beginning to end. And I'm going to get it all done because today's a good day. And if I don't do it today, I'll never be able to do it again because my pain will be worse. But then the next day your pain's a lot worse because you really overdid it. And then you're back in this cycle where you have to take a big rest for a while and then feeling bad about it and then spiking your activity again. So we ask you to kind of take some time noticing if this is a cycle for you. It is for most people with chronic pain. And then to think about how you can break that cycle, usually by trying some activity. Set a timer on your phone or your watch, right? So like, how long can I clean my apartment before my pain increases? Like, so my pain's a 5 on a 0 to 10 scale now. I'm gonna clean my apartment, set a timer. When it hits a 6, I'm gonna stop. And I'm gonna look at my timer. How long did that take? 15 minutes, 20 minutes? Okay, I'm done. I'm gonna rest. Tomorrow, I'm gonna clean my apartment for just 14 minutes and see if you can do that without your pain spiking. And so then you learn to kind of do these things in short chunks, as opposed to kind of having these giant overhaul days that then set you back. So we ask you to kind of think about your goals in life and how you can get there, but without but as comfortably as possible, right? Without spiking your pain. And then really, I just encourage you to think about communication with your providers. Again, really, most people go into doctoring because they want to help you and help their patients. They're feeling frustrated probably as much as you are. One way to get better results is often to schedule a separate visit with your providers to talk about pain. So that this isn't part of like another routine visit, or isn't part of a visit where you're talking about your acute virus that you have right now, or getting a vaccine or something like that. So that they really have time to talk to you. And try to explain how you feel as openly as possible, what your pain feels like, and how you feel your treatment's gone. And try to advocate there for your needs, including your use of medications. Be honest about how you're using them. Are they helping you? Are they not helping you? What do you want to do in the future with them? Are you looking to get off them? Are you frustrated because you don't understand why your doctor wants you to get off them? Do you want to try something different? Are you curious about surgery? Can you have an open conversation about that? Inquire about referrals for non-pharmacological interventions, some of the ones we mentioned here. Lots of health insurance actually cover not only cognitive behavioral therapies, but acupuncture, massage can often be covered. So have those conversations. Physical therapy is almost always covered. And then really attempt to reach some type of agreement with your provider about a treatment plan so that you're collaborating together in a long-term goal of how you're going to manage your pain. I just wanted to give a shout out to some additional resources that you might want to look into for yourself. So these are 2 great workbooks I highly recommend. You can go through on your own and do some of the kinds of treatments that we talked about here. So the one on your left, Living Beyond Your Pain, is a workbook really based on acceptance and commitment therapy. And the one on the right, Managing Chronic Pain, is a workbook based more really on the cognitive pieces of like changing your thinking about your pain. They're both very evidence-based, have lots of data supporting them, and easy to follow along with. I think really good resources. There's also a really great website, Chronic Pain Champions. It started by a not a medical provider, and he's very clear about that. He's a chronic pain patient who has done an amazing job of educating himself about causes of chronic pain, how to live with chronic pain, and all sorts of treatments for chronic pain, including cognitive behavioral therapies, mindfulness therapies, acceptance and commitment treatment. He has lots of links to great resources, and I definitely recommend you check him out. And then if your pain is related to fibromyalgia, this is a really wonderful patient resource group that I recommend you check out as well. And I think they're starting to branch out a little bit to non-fibromyalgia chronic pain as well. It might be a good place to find some support groups too. Thanks so much, Paul. I really appreciate you having me here. Thank you.
If you have a question after watching this webinar, then you can send an email to webinars@adaa.org. We invite you to visit adaa.org, where you'll find great resources, including a list of treatment providers in our Find a Therapist platform, as well as a free peer-to-peer online support group. And you can support ADAA by making a charitable donation on the website. Thanks, everyone, and thanks to Dr. Weisberg for a great presentation, and thanks to everyone viewing for watching. We encourage you to like this video and to share it.